Robin Goldman is an associate professor of internal medicine and pediatrics at UCSF, so MedPeds trained. She does internal medicine hospice work at the VA at San Francisco and pediatric hospitals work at the Washington Hospital in Fremont. She's also the director of evaluation for the UCSF HEAL initiative, which we've talked about and has come up in multiple talks throughout this week, which is a global health equity fellowship for those who don't know. She completed her HEAL fellowship in rural Haiti and her MPH at UC Berkeley. Her interests include applying social medicine to practice, global health education, program evaluation, creating systems to empower local providers to care for their communities. We're really lucky and happy to have you. Thanks, Robin.
Thanks for having me. Let me figure out screen sharing. Yeah, thanks everyone for joining. I am excited to be here. It's always great to talk to y'all. And I think Teresa did a wonderful introduction. I don't know if I have that much to add. I'm gonna, y'all seeing that in presenter mode at this point?
We're seeing it perfectly.
Yeah, okay. So my talk is going to be a little bit based on work I did in Haiti, and then I think a framework that I've sort of put around things and started to use as I got more in to the space of global health equity education. And yeah, and I think, as we mentioned, helpful to have some scrap paper and something to jot down later.
Robin, it just switched, so
I will. Okay. Sorry. Okay. So I'm going to be talking about structural analysis using a global health example, though I think can be used kind of anywhere throughout the world. And then I think let's talk a little bit about interventions. And I think for me, the reason that I thought to do this talk for you all is connecting sort of things I knew about social determinants of health and structural determinants of health to actual clinical practice felt hard. And so hopefully this is a helpful way to think about things. So I want to recognize that for those of us in San Francisco, I am on Aramitisha Ohlone land. And these are the people who have stewarded this land for many generations before we were here and will continue afterwards. And then I think just putting into context, land acknowledgements can feel kind of superficial at times. And so for those, an organization that I have been involved in to try to actually put some action around my land acknowledgements is called Segurite, which is for the is made of Lishan Ohlone people, mostly in the East Bay, and they are working. They both have programs and volunteer activities to actually like work on the land and do gardening and traditional practices, and are always looking for volunteers and work on actually getting more land sort of donated to their people to use. And so for those of you who are local, could be of interest. And my objectives here are to explore frameworks for the forces and factors that affect health outcomes, practice structural analysis, discuss the uses of structural analysis, and show an example of an intervention. And so I thought I'd start with just getting some voices in the room of if people can put in the chat, or I'm happy to hear in voice, why global health, or why health equity, like what brought you here into this week? And I can start as people are typing with me. I studied abroad when I was in college in Senegal, and I think that was, and while I saw a lot of inequity, kind of like where I grew up. I think the gap there was very big, and I really ended up just feeling like for my Senegalese friends that a lot of what I had was just the luck of being born in the United States to parents who were professionals and had stable incomes, and felt that there wasn't any. I think that's where a lot of my thoughts around like working hard and meritocracy started to break down. So that is what it brought me here. And wondering if anybody else would like to share. Oh, and someone's rating on this.
I think, would it be okay if people also come off mute?
Yeah. Voices, yeah, would be great. All right, so similar to studying abroad in Nepal during undergrad and disparities, mountains beyond mountains, also part of my path. And congrats on finishing the master's program. And then Teresa, again, bringing up sort of this geography of like where you're from. And then thanks for the people who are more Zoom savvy than me, but like learning through experience, and this idea of global is local, thinking about Native and Indigenous populations here in the US and what they've experienced. Well, thanks everyone. I am going to try, let's see. Okay, great. So I think one of the things as I started to try to like more formally think about global health as a discipline was around like what defines global health. I think like we all have a sense of I think even public health has like I think a slightly intuitive or a definition that's slightly intuitive for people who have been around healthcare. Clearly, things like cardiology and intensive care have very clear definitions of like what puts you into that field. Whereas global health, I think across the world, probably different people have different definitions. And so just to center our talk and how I think about things, these are some definitions from Paul Farmer's work, but that really global health, rather than a discipline, is a quest for equity. And it is multidisciplinary. And one thing I'm going to talk a lot about is that this goes from local to global and large scale, and encompasses social to molecular, and really involves a biosocial approach. And so what I feel like this emphasizes is that there are these like both micro components and macro components to what it means to practice global health. And so another model or way of thinking about this kind of micro to macro comes from kind of the public health world. And this is called the socio-ecological model, but really thinks about the individual or interpersonal factors, I think for us in our context, that affect health and how these are influenced by and surrounded by our relationships and interpersonal dynamics, which are surrounded by and influenced by institutions that we are part of, so where you work, where you go to school, and that those institutions are influenced and part of a community, and that a community is really influenced by policies. And so all of these things feed into like these effects on an individual person. And then thinking specifically about healthcare in the health field, this is another model. It comes out of the Population Institute in Wisconsin. But again, we have these like policies and practices in the US, like race dynamics, but again, other sort of axes of identity and structural, institutional, and systemic things that affect individuals. And I think what is one of the things to emphasize about this particular model is showing that how many factors, in addition to actual health care that you receive, affect an individual's health. And I think many people who go into healthcare really do so with the idea of wanting to help people be healthy or get healthier. And that is very important. And there are many other things that affect our patients' health. And then another sort of definition or background thing that I want to talk about is, so we've talked about working towards equity. And I think it's helpful to think about I think inequity is something that we all see and probably some of the time know when we see it, and for some people probably miss it some of the time. And there's kind of interpersonal inequity that I think is a lot of times like what people may jump to, and it's a lot of times of what we're dealing with in our day-to-day healthcare work or patient care work for those people doing direct patient care in the audience. But I want to bring this broader definition, and this is by Camara Jones' definition of racism, but you could pick any other axis of inequity, so race, gender, ethnicity, sexual orientation, but really thinking that our inequities are really a result of a system that structures opportunity and assigns value to people. And this will unfairly disadvantage some individuals and communities, unfairly advantage other individuals and communities. But one of the things that I find most powerful about this definition is that it really actually is to the detriment of all of society through the waste of human resources and having everyone be able to contribute fully to society. And so it's not that some people win or lose, it's that we all actually lose, even the people who have the power lose in a way that they're probably not aware of. And so that is a whirlwind of through some definitions and models that hopefully are helpful as you think about the structures you notice around you. And now I'm actually going to move to a case. So I think a lot of the times I think, I spend time like thinking about and teaching structural analysis. And then for those people who are working with individuals, so either in the healthcare setting or in a public health setting, it's like, okay, so I can think about all these things and I can learn about them, and I can learn about like racism and housing policy, for example, in the US, or various genocides against Native American people and forced relocation. And I'm in clinic, or I'm in the hospital, and I just have to see patients, and how do we connect these things? And so, as Teresa mentioned, I did a global health fellowship called the HEAL Fellowship in Haiti, and was working in rural Haiti, kind of on and off for two years, and then even beyond my fellowship. And I think early in my fellowship, saw a patient like this. So 2-year-old presents with her mother, and mother says that she's been really fussy, had diarrhea. And so I was just wondering if people could volunteer what questions you would like to ask, what you think might be going on. And feel free to do in voice or in the chat, whichever you're more comfortable with.
Any fevers? How long has this been going on? Has it happened before? Any exposures to contacts? What's going in? What's coming out?
Yeah. So let's see. Fevers has sometimes felt a little bit warm. They don't have a thermometer at home. But also very hot. So mom hadn't thought too much about sort of the warmth to touch. No one else in the family is having diarrhea. This diarrhea has been going on for a number of weeks, and it seems to just kind of like be getting worse, or at least not getting better. Let's see, they drink, diarrhea is not bloody. They get water kind of from a local stream, and sometimes they're not able to boil it, though not always. It just depends on like how much charcoal they have. They're eating about one meal a day. The most commonly is rice with a like bean sauce, and put whatever vegetables they have on hand into that. Anyone have thoughts on so mom's not sure about weight loss, but has not kind of been growing that fast, and yeah, legs do look a little puffy. And then sort of interest in eating, had been interested, and just has kind of gotten like a little more listless over the past few days, which is what prompted her to come in.
With the diarrhea, thinking probably infectious, with how long, maybe either bacterial or parasitic, with like possible exposure with the water that's not always boiled.
Yeah, good thought. And so stool studies, probably something that you want to think about here, though many would argue to just maybe go ahead and empirically treat for parasites. Any other thoughts about what else might be going on? I think Brittany,
If it's been going on more of like her whole life, you could think of like malabsorption or something that wasn't picked up when she was younger, if she hasn't been growing and all of that.
yeah. 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 And Brittany, I think you kind of brought this up in like the appearance of the picture. Um, but yeah, so malabsorption or like just not enough going in. And so is this malabsorption or actually just worsening malnutrition? And so I think that and you guys or Brittany, you were right. This is a malnutrition clinic. This is I didn't see this specific patient, but this is sort of the place I was when this happened. So it is malnutrition, very common in Haiti, and I assume has only gotten worse in recent years since I haven't been back with the political instability. So I think good to think about, like, a very reasonable to do stool studies in this patient to look for parasites or infection that could cause an acute worsening, but also has an element of chronic malnutrition. I think usually in these scenarios, with that kind of dietary history, we'd go ahead and treat for just protein calorie malnutrition. And then if not responsive to that, think about, do we need more of a workup for something else that's going on that's causing a lack of absorption, but trying to get the protein and calories in there first and seeing how that goes. I was working for Zami La Santé, which is the Haitian branch of Partners in Health, and they have a pretty robust malnutrition program. The packet that you see here is something called Nurimamba, which is their manufactured version of plumpy nut, which is sort of what is, I think, available more globally outside of Haiti. I think there are clear treatment algorithms for whether or not someone can get outpatient treatment for malnutrition versus needs inpatient treatment. And so from a treatment standpoint, actually, this is a relatively straightforward case. I mean, maybe a few things to work up here and there, and clearly some observation needed to make sure that she's responding to treatment for just protein calorie malnutrition, and potentially also treating for parasites or other like water borne diarrheal illnesses, but all, I think, very treatable on an individual level. And so then you can take, so like you could just like go through these kids and continue to treat them. I think the malnutrition clinics in the part of Haiti that I was in are very busy. But I think this is where both like the people at Zami La Santé and I think as well as myself is like, okay, so how did this happen? And so maybe if people want to volunteer by voice or in the chat, like what factors do you think led to malnutrition in this kid?
I think the water source could be contributing. If you have diarrhea, you don't eat, kind of like this vicious cycle, get infections.
Yeah. Yeah. Mm-hmm. right. And I will not try to make people make assumptions about a place they have never been. But I started thinking about this over, I think, not a kind of initially when I went to the malnutrition clinic. And I will say I initially went to a malnutrition clinic as kind of part of my orientation to like, these are the types of services we have. These are the things we do. We want you to see what our community health resources look like. And so clearly, if you end up in malnourishment, there's difficulty getting food. And then I think as I learned more about Haiti and specifically the parts of the sort of more rural parts of Haiti that I was in, I talked, I actually on this day, I talked to a couple of people in the community who were talking about like why it's hard to get food. And they actually mostly talked about farming, so that they try to farm food either to sell at a market or to eat themselves. But that more and more recently, there have been these like big rainstorms that kind of wash things out and ruin their crops. And so, what happens is that when they don't have crops to sell, what they end up doing is actually cutting trees to get wood to make charcoal, because they can sell the charcoal, and so that provides income to the family. Realizing that and I think the people in this community had insight that the trees were kind of thinning, and it made it easier for kind of the soil to wash out when there were these big rainstorms. And so you have this whole kind of set of circumstances that lead to low crop yield that are kind of end up being self-perpetuating over time. So that's what they talked to me about. And then I think as I spent more time in Haiti, there was a different sector, right? So maybe not your farming sector, but like people just need money to buy food, and unemployment in rural Haiti is very high. Most people do not work in the formal sector. Most people don't feel like they have access to job opportunities. And part of this is because access to education is hard. There are school fees that people have to pay. The language for school is in French, as opposed to Haitian Creole, which is what the majority of the population speaks. But if you don't speak French, you again have decreased job options later. Part of the reason that people don't have access to education is because there's not enough funding for education and public services. And the government doesn't have money for many reasons, but partially Haiti historically was under an embargo for a very long time after gaining independence. It was the, I think, only successful slave revolt to like end up beating the colonizers and forming their own independent country, but was then put under embargo by most kind of Western nations, so Europe and the United States. And then France actually, until the 90s, was collecting on a debt to them for like lost income from the crop, which is crazy. And so that gets to racism. And so there's all of these things that like funnel into Haiti, not like the government not having enough money, and leading to the effects on the population. And that is all stuff that was present before the current sort of period of real political instability. And then I think I have since added things around kind of poverty leading to gang violence and government instability, agricultural policies, as well as like international patent policies around nutritional supplements, and all kind of influencing everything that's going on. And yes, thank you, Teresa, for linking that. It's a really kind of what is the best word for this? Damning, but also in a lot of insight into this New York Times investigation into the insight of the debt in Haiti and the economic effects of it. So that is my kind of structural analysis of this child with malnutrition. And I did this over time. It is not something that I like kind of like was able to do after one clinical encounter. And I think it helped me to frame all of the different things that my patients were going through. And I think also provided avenues to think about where else can we do interventions other than just at the patient level. And so I think I'm gonna stop sharing there and have us take maybe about say 4 minutes to think about a patient you have seen and try to do or someone in your life. So it doesn't have to be, it can be in your professional life, or it can be in sort of just your experience in the world. And take a second, everyone can turn cameras off if they want, but take a second to think about just trying to start jotting down all of the factors that may have led to like what brought that patient to you with that particular problem. And then we'll come back at 12:25 or 25 after, wherever you are, and kind of just talk about how that felt. To people, how did like actually trying to map all of these various like social and structural issues to an individual feel?
A little overwhelming, frustrating. There's so much we can't control, or that a 2-year-old patient can't control.
Yeah. Yeah. Okay. All right. So a lot of people feeling overwhelmed.
And I feel like I'm always like, wow, I feel like everything leads to everything in a sense. So it's hard to kind of pinpoint one path, but it's always these double-sided arrows.
Yeah, and it makes the drawing really messy. So like when I try to translate this onto a slide, it's like I have arrows going through words and back and forth. Other feelings? Did everyone feel overwhelmed, or did anyone have a different feeling from doing this?
I was surprised at just like how much I found myself continuing to branch. I was like, oh, I must be like reaching the end point. And then I'm like, oh, wait. And it just kept going and going. And I guess kind of like overwhelming too, that it felt hard to find like a stopping point because you could keep going.
Yeah. Yeah, I totally agree with that. All right. well, thank you all for going through that exercise. And I understand, and I'm sure actually seeing me talk through things kind of felt overwhelming. And I think, and this was with like input from the community. I think I agree that it is overwhelming and there's so much stuff. But I think one thing that actually trying to map and write things down is it like got me beyond, and I think this is to your point, Erin, it got me beyond like my couple things, like these people are poor and they don't have enough money to buy food, and they have jobs, they don't have like consistent income. And it got me to think a little bit beyond that. And I think I personally am kind of going into my experience in Haiti, just hadn't thought as much about like the specifics of like climate change and how that was relating to malnutrition. Again, this was 10 years. So like climate change was there. I think it was maybe as the increase in like we weren't quite where we are now in terms of like how frequent climate events are. And I think the hurricanes that have affected Haiti that were all, I think, after this initial analysis for me. But so I think it helped me broaden like where do people need help? And so I think while overwhelming, it also showed a lot of potential interventions that are like potential for areas to intervene that weren't like fixed poverty. And so I will go back to screen sharing. So, I think to the point of, so there's all these things, again, like I know nothing about agricultural policy, and I have not chosen to go into that world. I also, the idea of changing an education system in a country I am not from or didn't work in, it does not feel appropriate or within the realm of anything that I do. And then when I think about my current practice here in the US, there are a lot of factors, things affecting patients that feel out of my control. But when you look through the literature about acknowledging the social and structural determinants that affect health to your patients, and how to apply this to the clinical world, what people have found is that like making clinicians thinking about these things really increases empathy from the clinicians, and that patients actually report better relationships with their healthcare providers when we talk about and ask about the social determinants that they're faced, even when you can't do anything about it at all. So I think that is a pretty strong argument of just like the empathy and improved relationships are a strong argument to like spend a little time like thinking and asking people about the things that are influencing their health and sort of the social and structural barriers they face. And then the second sort of area that I think is important to think about is that it's that no one can change things if someone doesn't identify something. And so again, talking to patients about their story, what they've gone through, what their stressors are, helps challenge implicit biases, and can lead to systems change, even if you're not the one doing it. And I would say, as people in the healthcare, or for people in the healthcare field, your voice can help make change, and has a lot of authority that comes with it, even if you don't feel like you have that authority, but just because of your position as a healthcare worker. And so I'm going to talk about an intervention that came out of, I think, people starting to do this social and structural analysis of malnutrition in Haiti. And I was not involved with this. This already existed by the time I was working in Haiti, but from talking to people, so, the Haitian providers and like Haitian community members at Zami La Santé sort of, started these malnutrition clinics. I think one of the barriers they faced was that plumpy nut, which is sort of the global treatment for malnutrition, is actually patented and fairly expensive. And I think there were discussions with communities about what was happening with crops, and kind of like crops flooding out with bigger and bigger rainstorms. And at some point, someone from Zami La Santé and Partners in Health were talking, and then were approached by someone who actually, it was like a professor within agriculture at I'm not remembering what university, but somewhere in the southeastern United States, who got interested in this and actually wanted to help address like sustainable farming practices. And so out of that, I think, came a partnership and the founding of an organization called Zami Agricole. Zami means friends. So like Zami La Santé is friends of health or partners in health, and Zami Agricole is friends in agriculture or partners in agriculture. So this group kind of did their own fundraising and actually started a sort of sustainable farming, along with this sustainable animal husbandry program that would get referrals from Zami La Santé or Partners in Health, so from the healthcare clinics of people who actually like really needed help. And this involved both teaching sustainable farming practices, as well as this like goat loan program where they'd loan people a goat, and then when the goat had babies, they'd like give the babies back as to be loaned to someone else, and so that was like self-sustaining in a way, and then eventually actually started an actual like farming program, and one of the things in the farming program were peanuts, and peanuts are the main ingredient in plumpy nuts. And then kind of separately, a different group of folks like kind of went into negotiations with plumpy nuts to try to get their patented recipe, and eventually got to the point that if they were given the recipe, if they promised not to ever sell what they were making and not to share it. So another group made a factory to sort of manufacture their own plumpy nut, which they call Nurimamba, which is Haitian Creole for like nutritious peanut kind of thing. And the Zami Agricole now grows the peanuts that go to the Nurimamba factory that then go to the clinic. And And this is all to say that, like, yes, everything is interconnected, but these were different groups of people who took in like an intervention sort of like in their area of expertise. But none of this would have ever happened if the healthcare providers that were seeing these malnourished kids and talking to the parents that were having trouble feeding their kids about what was happening and why this was so hard. If those clinicians had not talked about that, none of this would ever have happened. And so I was really inspired by this, and now they are their own sort of more self-sustaining, and Zami Agrifol has actually like expanded to capacity building around a lot of different sort of agricultural practices in Haiti. And and I think I brought this up already, but when I think about sort of the institutional things that really can affect our ability to treat malnutrition, the patents over like recipes and drugs, shipping, and then cost of healthcare. And cost of healthcare is actually a thing that at the clinical level, Zami Lassentier intervened on. Most government clinics in Haiti have like a fee that you have to pay to see someone or to access care, and they got rid of user fees in their clinics to improve access. And so I think all of these, so there are some areas where like we as healthcare providers can advocate at our own clinic or at our own institution to change some things to help patients. And then there are some things that like are other people's areas of expertise, but they may not know about your patient's needs unless you start talking about it. And so this is also a framework from Kamara Jones's work, but in sort of she mostly focuses on racism in her anti-racism work, but I think again goes for any inequity or disparity. You need to name it, ask how it's happening, and then either act to create change yourself or just tell the people who you think might be able to actually act. Like this is not all your job, but I think talking about it may inspire other people to create change. And I think this is things I've learned, but thinking about wherever you guys are doing work, if it's not the community you're from or a community that you know really well, try to learn about the history of where you're going to work. I think a lot of my Haiti diagram came over time from learning about the Haitian Revolution, the debt issue with France, and sort of American invasions over time, and then talking to people in the like education and farming space that I just like happened to run into over the course of my time there. If you're interested in learning more about structural competency or structural analysis, structuralcompetency.org has resources from this group called the Structural Competency Working Group that was started actually locally here in the Bay Area, but now does, I think has people in a much wider geography. And then the New England Journal of Medicine has these case studies in social medicine that I also sort of talk about how people have made sort of social interventions to help their patients, and can give other examples of things people have done. And those are, sorry, I see that there's something in the chat. Those are all my slides. And happy to answer questions. And I think, yeah.
And I just put those links in the chat too for people in
Thank
case
you.
you didn't catch them from the slide.
Thanks, Teresa.
From your work in Haiti and with the HEAL Fellowship, how much of that influences kind of your day-to-day practice here in the Bay Area?
Yeah, I mean, I think it definitely influences how I think, and if I sort of compare myself to the hospitalists that I work with, I think I probably bring up social and structural factors like in our just discussion of patient management a little more often. Though I do think that actually, particularly my adult group at the VA, like there's a lot of work around like the marginally housed, like that's a big issue. And so I think at an institutional level, they are thinking about that a lot. Of like how do we get people into housing with the hope that they will stop, or that will help them stay out of the hospital a little bit more. And I think I have probably at this point in my life done a little less like advocacy work at the like regional and national level that I like. When I was in residency, I did some of the like AAP go to DC and talk to representatives, which is fun. Even if you've like never done anything like that before, it's just kind of like find one person to go with you that and then go around and talk to people, and it's a lot of fun. And I think if you vote in California, then you probably will get like a pretty warm reception. I think I went with someone who was from Wisconsin, so it was like talking to Paul Ryan about expanding healthcare access, and that was like a more intense conversation, though she was really happy to have it with them. But I'm in a phase of my life with two little kids where like the traveling and national advocacy is a little bit harder to do. I think I have surprised myself even with some interventions when I start asking people about like, do you have access to a bathroom so that when we give you furosemide, you have a place to pee, and like troubleshooting around that. Or I think, recently talking to someone about a person, this is an adult with cirrhosis, and they're lactulose, and like how they had to time it around like car trips and things like that, and when they had access to a bathroom. So I think it does kind of come into my work, and I probably would like to be able to do more. And it's just like this is not an everyday thing, but it's like what you have bandwidth during some of your like time to breathe, wherever that comes.
And is your approach any different since you do both pediatrics and medicine? Do you approach those patient populations different when you're doing this kind of structural analysis?
I think pediatric training is better at thinking about at least the whole family, if not like the environment that a patient is in, than adult medicine. I think adult medicine is much more like it's less integrated into how people are trained and how people practice to like really spend time talking with with family, unless it's about like acute illness decompensation, at least on the hospital side. I'm sure primary care does a better job than hospitalists do about thinking about people's life. So I think yeah, for people who are trained in pediatrics, you kind of like already have a leg up on this social analysis compared to many medical specialties. I think there is a part for those people based in the US. It is easier to advocate for children, I think, or like ask for policy changes for children. I think that's just something that hits home for policymakers and people, like creating programs a little bit more than adults, because there's a little less like individual blaming of children, I feel like, than there is of adults. For a very like US culture, like that's like just culture here, that we do a lot of individual blaming.
Other questions from the group, either come off microphone or feel free to put it in the chat. We will put a survey link in the chat as well. Thank you, Tiffany. So please take just a minute. It's only 3 questions, but we really do value your feedback. Go ahead. Yeah, Robin.
Yeah, and I just gonna say, I just put my email in the chat. I'm happy to talk to people about like structural analysis, but also happy to talk about like careers in global health. And I think, as mentioned, I chose to do a fellowship in global health, which I felt was really helpful, and it's actually like made me most of my connections that I have now. So if that's something that any of you are thinking about along the way, I'm happy to talk more.
Well, thank you very much. Really appreciate your time.
Okay, great. Wonderful to talk with all of you.